Hello and welcome to Pain Unfiltered, where we go in-depth into the interventional pain and spine world with some of the top key opinion leaders and executives in the space. We are your hosts, Dr. Patrick Buchanan and Dr. Timothy Deer for this ASPN podcast. Let's get started.
I am Dr. Patrick Buchanan, and with me is my co-host, Dr. Timothy Deer. Tim, we've had a lot going on around ASPN recently with another season of the post-operative program launching, a new AI division starting up, and ISPN approaching. Why is now a great time to get involved in ASPN?
Patrick, thanks for that question. And hello, gentlemen. Good to see you all tonight. So we did a lot of things, as we went around the annual meeting. We, number one, created the AI division. And we have so many smart people in our society. And I think, again, the AI division is looking for people to help them. There's so many projects. There's machine learning. There's large language projects. There's, all these things out there that really need input. There's, new avatars to do things like informed consent. So Robert Mogum, I was just out and visited him in Denver a couple of days ago. He brought John Pritzlaff and Usman Latif on to help him run the program, but we need probably another 100 volunteers for that program. So certainly encourage everyone to think about joining us there, particularly those who are that type of mind. David Dickerson, I just spent a couple of days with him in Austin, Texas this weekend. He's running our MIS certification program, and the support for that among not only interventionalists, but also among surgeons has been quite great. Had a lot of input from ortho, spine, and neurosurgery. And then, ISPN, Dubai, we thought we'd have 100. We had about 300 people. England, I thought we may have 300 or 400. And, I think we may get close to 1,000 people there. So the growth of that society is really good. A lot of people, they like neuromodulation, but they also want to learn about that, which we'll have there in England and London, but they also want to learn about MIS. And this will be the first time that many of the MIS companies have ever gone to Europe and to the UK. So I think that we'll expose our colleagues around the world to that. So I could go on and on, Patrick, but we only have so much time, but I think it's an exciting time. And certainly anyone who wants to get involved, I think there's space and room for you to be this. And we look forward to just having more people come in and collaborate with folks to help their careers.
Yeah, it's just a credit, Tim, for what you and Dawood have built all of this together, and just getting members together, collaborating, and kicking off these new initiatives. If you haven't been a member yet, sign up. Member, we'll put the link below as well, and please get involved. Reach out to one of us too if you need any. We would like to welcome a new sponsor to the podcast, Biotronic. This is their first time sponsoring, and we couldn't be more grateful. Tim, give us a couple of thoughts on Biotronic.
I've had the honor to meet the owner of Biotronic. I've been to his home in Berlin, and just really great people who are patient-focused, and they're really into remote monitoring, which I think really is they have so much data. And recently I talked to Todd Longeman, their president of Neuro, about writing some of that data up, because, data is very valuable, but it's even more valuable when you publish the data. So we're talking about that a bit, and I think Biotronic has really been very impressive, and they need to continue what they're doing, which I'm very impressed with. And I look forward to seeing some of the publications of that remote monitoring data, because we'll learn a lot from that. And I think it'll help us with long-term outcomes. So we really appreciate the support of Todd and his entire team.
Yeah, incredible innovation and data, and incredible company, and looking forward to see what they have coming up as well. We also want to thank some of our other sponsors that have supported ASPN podcast this year. Mainstay Medical, Saluda Medical, SPR, and Spinal Simplicity. Thanks again for all your support. So, Tim, today we're going to turn our attention to peripheral nerve stimulation, which has been growing rapidly over the last couple of years. We have a couple of West Coast physicians here today with a tremendous amount of experience using this therapy. Let's introduce Dr. Samir Seth from Sutter Health. He's an interventional pain specialist in Northern California. And Dr. Scott Pritzlaff, Program Director at Pain Medicine at UC Davis. Thanks for joining us, guys.
Thank you. Thanks, Tim. Thanks, Pat. Really
Thank
great
you, Tim.
to be
Thank
here.
you, Pat. Yep.
Perfect. So why don't you guys just introduce just quick background and kind of how you got there. Scott, we'll go with you first, and then Samir will have you.
Sure. Yeah, absolutely. Thanks, Pat. I have a little bit of a extended, circuitous background to where I'm at right now. I'm an anesthesiologist by training, both by training at Mass General and my pain fellowship at Stanford. But as some of you know, really proud of my time after my internship. I actually spent 5 years on active duty as a naval officer with the U.S. Marine Corps. So actually became very interested in pain during those years, during some of my deployments overseas. And so really saw some of the potential of blocks and looking at veterans who had a lot of trauma, extremity trauma. And I think this has naturally flowed into this conversation with PNS and peripheral nerve stimulation. So happy to be here.
All right, I'm also in Sacramento with Dr. Pritzlaff, and I actually graduated from that same fellowship program. I did anesthesia at Columbia University, and then again I did my training at UC Davis under Scott Pritzlaff and Paul Crease, and had a very good training there, and stayed on for about 8 years before wanting to just try something different. So I just went out in the community, and now I'm working at a large healthcare system in Northern California at Sutter Health, and I've been there for about almost 7 years now. So what's nice about being in our area, though, is we still get to work with a lot of the other physicians and collaborate. So people like Dr. Pritzlaff that I get to talk to quite often and ask questions to, and make sure that I'm staying on top of my game. So again, really like to thank Tim and Pat for having us here tonight and talk about an exciting topic. So thank you again.
Thanks, guys, for joining us. Well, let's dive right in. We'll talk, have our discussion mainly centered around the 60-day peripheral nerve stimulation guidelines that ASPN put out. We'll turn to you first, Scott. Kind of how did that develop, since you, Samir, and Tim are some of the lead authors on this paper? How did this kind of start out, get created, and explain kind of the methodology used to create this?
Well, I think what's interesting is with PNS, as we all know, a lot of these percutaneous commercially available systems, I mean, this is relatively new, the past 8 or 9 years. And although there were reviews and even consensus papers, really there was no distinction made for 60-day PNS. And so I think this paper and this guideline really fills that void. And I think it's also impactful that a lot of the authors on this paper really have extensive experience with both 60-day PNS as well as some of the other permanent systems. And so you're really looking at a wealth of expertise and those who are practicing in a really broad spectrum of environments, whether it be private practice, academia, or even some of the authors, for example, Denise Lester, working in some of these VA environments where a lot of these data really came from in the beginning. And so I think this paper speaks to that diversity, and it speaks to really that it was time to hone in on this therapy in particular to give some good guidance.
We saw an unmet need there, and I think you all played a great role in trying to make sure that was a very helpful paper. And I think, Scott, your points are very well taken. By the way, congratulations on the Armed Services Award behind you. We appreciate your service and helping
Thanks,
so many
Tim.
of our soldiers. But Samir, I think one of the things is we go through that guideline, we look at the grading system for evidence there was a lot of evidence on the 60-day treatment. And then we come up with some recommendations based on that evidence plus our opinions as experts. What are some of the main take-homes? We have a lot of fellows and residents listen to this podcast. What are some of the main take-homes you think from that 60-day guideline paper?
Well, I think the main take-homes, really that there's a vast amount of research out there supporting the use of peripheral nerve stimulation. I think this paper really came together and highlighted some of the strongest papers available so that we can really develop some really strong methodology and strong recommendations regarding the 60-day peripheral nerve stimulation system. So I think, when you look at some of the main things that this highlighted, it really highlighted how effective these treatments were for low back pain, for knee pain, and also for post-amputation, really phantom limb pain. So, really highlighted how much, and we'll speak to this a little bit, I'm sure, throughout the podcast, but a lot of these insurance companies will come to us and say, there's no evidence, this is all experimental. But what this paper really highlighted is showed how much evidence there actually is, and really organized it for our fellows and for our younger physicians who aren't aware of all the data that's out there. So I think this is something that really helped change the perceptions about this modality. It really reminded many of us of how much history there is with peripheral nerve stimulation and also the efficacy behind it. So I really, this really was nice to be part of, to really make sure that we're understanding how effective this therapy is.
Sky, you mentioned that you created this partly because there hasn't been anything really done with 60-day peripheral nerve stimulation. How does this differ from the traditional trial to perm approach with conventional PNS?
Well, I think one of the limitations or one of the concerns always with traditional, I guess, permanent systems has always been this idea of, is a 7-day trial, is that enough? Are you going to capture the patients who are going to do well, right? And I think what this paper speaks to is this idea that not all patients are going to respond in that very short, brief period of time. And in fact, if you look at some of the data and some of the responder rate data that is discussed in the paper, we see that there are perhaps 30% of patients who declare themselves after 14 days. And we talk about these conditions that are solidly chronic, historically very difficult to treat. I point out, and Samir mentioned this, phantom limb and residual limb pain, something that has historically been thought as a central pain condition, which I agree with. But those patients take a while to respond to peripheral nerve stimulation. And so I think where this is impactful is for some of these patients that take time to show that there is good evidence that, maybe at 3 or 4 or 5 weeks out, that patients will respond, and evidence to show that there's durability, that this is really a paper that shows even with a temporary therapy, something that is only in situ for 60 days, that you can have durable benefits long beyond up to 12 or 14 months beyond the end of therapy. And I think that's something that we've really never looked into with this level of granularity and depth in the scope that it's done across multiple organ systems or areas of the body and multiple conditions. And so I think that's where this is super impactful and really offers a roadmap, not just for physicians, but also for payers, as well as for patients to understand that there are all these options available. I also wanted to say one more thing. We talk about chronic low back pain and this idea of centralized low back pain. And I want to make it clear that things like spinal cord stimulation, which have great evidence for axial back, that we are not throwing that out, right? We're just saying, I think for some patients, this can be introduced much earlier in the treatment algorithm and can be something that can be done in a minimally invasive, low-risk manner. And those other therapies are still very much on the table. And so once again, I think this paper and these guidelines speak to that this can be introduced very early in the treatment algorithm, something that historically has not been emphasized with some of the other systems or types of PNS systems out there.
I want to ask a follow-up question, Scott, to you, and then Samir, I have a question for you. I think it's a really good question. You'll be the judge of that when I ask it to you. So, Scott, you mentioned something. I presented some of this. There were 6,000 patients, I believe, in that look at early responders and late failures. I mean, right? There was two groups: people late responders you would have missed with the normal PNS trial, because it may be 14 days or later. Then there's another group that responded really well, but about day 21, they dropped off and they would have failed a permanent PNS, right? So led to
delayed non-responders.
Can you speak for a moment about the delayed non-responder? And what that may mean economically, it may really I think it may save a lot of money for insurance companies to not put in someone who would have failed. What's your thoughts on that?
Yeah, I mean, I think all of us will agree, right? One of the most demoralizing outcomes in neuromodulation is that patient who goes through a trial and you implant them with a permanent system, and then they come in 3 or 6 months later and say, hey, this is kind of fizzled out, right? And in many cases, you have implanted a very expensive, very elegant, technologically advanced, but very expensive system. And so the fact that you once again can potentially identify delayed non-responders, those who are going to initially have benefit and that benefit curtails off, I think is an economical no-brainer in the sense that it makes sense. And it also allows you to really hone in on, once again, who's going to be a really great candidate long-term for PNS. And the great thing about a temporary system is, in the event, by the way, that someone's either a delayed non-responder or they're a responder, but you take out the system and their pain returns, you have really shown and gotten really good data to see who should get a permanent device and who should not. And I think it makes sense. It's good for patients. And certainly when you're looking at long-term costs associated with payers, I think it also makes extraordinary sense. And I know Samir also has some strong thoughts on this as well, about payers and how we're good fiscal stewards of the money that we have and to treat these patients with these therapies.
Yeah, I recently published an economic outcome analysis of a paper I did on non-surgical backwards stem, and I think the insurance companies appreciate that when you look at that very carefully. So, great point, Scott. So, Samir, here's your question for me. I think it's a really important question for our listeners. So, you get people that have, a shoulder surgery, they have a replacement shoulder, their shoulder's killing them still. You get someone who's had a sural nerve injury in their lower limb, and the thing I get asked often is that a 60-day PNS patient, or is that a spinal cord or DRG patient, right? So how do you decide, or they have groin surgery, for example, how do you decide when you're going to go to the periphery and do a 60-day therapy versus going directly to the spine? What's your advice to younger listeners based on this guideline?
Yeah, Tim, I think that's a great question. And I think that's something that it's something that gets teased out. Certainly, when I was doing this, I kind of had to experiment myself with trying to figure this out. I think bottom line, I think Scott touched on a lot of points there that were really important. First of all, this delayed responder data, I think, was really, really key. And some of these patients, especially those difficult peripheral nerve injuries that, don't respond initially, I think those people who are delayed responders, just imagine how many people, it's about 30% of people that actually respond. So we would have said early on that those people would not have responded, would not have offered them any sort of permanent device at a conventional trial. So think about how many other people that we're actually helping by kind of using that knowledge that we have. But then again, when you're looking at all the patients across the board, so Tim, you brought up shoulder pain, maybe sural nerve injury, maybe let's talk about knee. It's about 10 to 20% at least. I mean, some of the data, at least 10% of the people who undergo surgery for shoulder, for example, have chronic pain after. 10 to 34% of patients with knee pain, knee surgery have pain after persistent. So this is not a small population that we're dealing with. But I think at the end of the day, what I looked at and what I realized is that, again, I think Scott touched on this point that spinal cord stimulation has a very, very good therapy for a lot of patients. However, this is another option for patients. So peripheral nerve stimulation, so I've offered this earlier in my treatment algorithm because I look at it as, again, a temporary therapy that could potentially have durable pain relief. And I look at it as a patient-centric approach. So if my patients come to me and they said, I want to try something that is a safe, effective therapy, I can potentially offer this. And, if it works, great. And if it doesn't, then, or if it works for just that 60-day period and then pain returns, there's still something else to offer these patients in a stepwise approach. So long answer, try to shorten it up a little bit. But basically, I do think offering this earlier in my treatment algorithm has been very impactful for my patients. I know there are patients that I've had with crips, for example, that have done extremely well. I mean, really just couldn't even walk. And then we've done these therapies and really just life-changing for a lot of these patients. So I think that this is something that, again, given the evidence that we have and given really the safety of this procedure as well as the efficacy, it seems like a no-brainer to offer for me early on in the treatment algorithm for those patients. I also think of it, I think some people use it as a gateway to neuromodulation. It's a nice therapy that we can offer these patients and kind of make them aware of all the different possibilities with neuromodulation. So I think this is something that's really important.
I think that may be the title of this podcast, the neuromodulation. Patrick?
There you go. Tim, I thought that was a great question because it leads me right into my next question. I'm going to have this with Scott here. So we talked about, what would you do in what cases? What patient populations do the consensus guidelines recommend or suggest that, patients would most likely benefit from a 60-day trial?
Yeah, so we talked a little bit. I mean, there's a great table that goes through the evidence grading, but really the patients that both stood out from the paper as well as, we spoke about them a little bit earlier, those axial low back pain patients who you may have that thought that they have centralized axial low back pain. They may not have responded to other therapies. And, there's this whole movement, this whole focus now on the idea of, reconditioning proprioceptive input to the nervous system, that you're going to help that multifidus to fire and re-engage and reactivate. So the evidence and the recommendations were strong for ASPN on those groups of patients. The other group of patients we touched on a little bit that I think I personally have had some great wins on are these post-surgical knee patients, post-operative refractory knee pain. And John Gurry did a really nice RCT that was published about a year ago looking at these patients. And I think, speaking to data, by the way, when we talk about data, that study, I think was novel in the sense that they were looking at walking tolerance and how far patients can walk, right? Which I think is great because we're once again focusing not just on pain, but also function. And in that study, they were targeting both femoral and sciatic nerves. So another great bucket of patients. And then the last, which had strong evidence, were post-amputation patients, those with residual limb and phantom limb pain. I know personally for me, I've had several upper extremity amputee patients, certainly not some of the patients that Chris Gilmore published on, but nonetheless analogous. And it's really interesting to me. And still, I kind of shake my head in disbelief that you can stimulate from the periphery and someone can tell you 6 weeks later that their phantom limb is different and their phantom limb pain is different. And the fact that that can be durable really shows that you are modulating and augmenting central processes from the periphery. So those three buckets of patients, I believe, are great patients to target if you're just getting in to peripheral nerve stimulation. There's sound evidence. And technically, when you're talking about just the technical aspects of doing those patients, once again, very approachable. It's not like we're targeting some of these smaller distal nerves that require very granular ultrasound skills that, I love that stuff. But I would say when you're first getting into the therapy, you want to find some buckets of patients and collaborations that are going to fit well with your practice and that you're going to be able to do these procedures with relative ease and feel safe doing so.
No, Scott, I think that's a tremendous answer. Samir, I'm gonna tell you a little story, and then I'm gonna ask you a question. So I had a patient the other day, and I was doing a posterior lateral orthodesis for L4-5 spondylolisthesis with leg pain, and she did well. And I went to see her. I was, in between surgeries, I go back and see the previous patient before they go home, and her husband was with her. His name was Junior, and he said, "I hope you help her as much as you help me, Doc." And I didn't recognize him. And he'd blown off half his hand. And I had done a 60-day PNS on him about 3 years ago. And we had done, and my nurse practitioner had chosen the patient. We did this procedure. We had done a median nerve 60-day trial on this guy. And he had been suicidal before the trial. And I said, if it works, we may go back and put a permanent device in you. And after we pulled it out, his pain was gone, and he was able to use he had three remaining digits, and he was able to use his hand. And he was actually a barber. He was a 70-year-old barber. And so he came back and said, you saved my life. And so I was treating his wife, hadn't seen him in 2 or 3 years. And that made me feel so good. It was like the best day I've had in a long time, right? Just knowing that. So I asked you that, I tell you that story because here's I think, a very important question. We have a lot of listeners who are in Omaha, Nebraska, or rural South Carolina, or, some small town. And, they don't have the chance to go out to a lot of meetings and things because they're busy. They have a busy practice. And, how do they take these guidelines and apply those to their daily practice so they can change lives? What's your recommendation? What would you take from these guidelines to your practice in a small private practice somewhere?
Yeah, that's go ahead.
Go ahead, Samir.
Okay, well, I was going to say again, it really highlights. I mean, everything in this paper kind of organized everything into nice tables, and what you can see, evidence behind it, as well as recommendations. So really, a consensus of a lot of great. I'm honored to be a part of this paper right now with all the people that are on there. But really, just kind of organizes those thoughts. But also, more importantly, it kind of speaks to a lot of the other advantages: the durability of the 60-day therapy, the safety. It highlights the safety of 0.1% infection rate. And again, the really the approachability of it. So this is something that you don't need to do. You don't need, you can do this as an outpatient with local anesthetic. So again, from a patient-centric approach, really something that doesn't require an anesthesiologist or CRNA to do the sedation. You could do this and get away with local anesthetic, which I think is really, really nice for a lot of these rural centers that don't have access to a lot of the stuff that we may have in larger centers. So I think that this is, I hope, opening the door and making people realize how effective this can be for a variety of different pain conditions. Not just, Scott highlighted some really important ones. So post refractory knee pain, phantom limb. You got your low back, which again, that's a huge patient population, but there's all these promising areas that we haven't really even touched upon, like shoulder, occipital. I have so many different cases of occipital pain for patients. Like you said, Tim, they come in and they're crying. They're crying because they weren't able to read a book or turn on the lights in their room because of their headaches that were just so bad. So I'm hoping that this helps change that perception regarding that 60 days of therapy is only 60 days, but in fact, it's more than that. It's actually a durable outcome that can actually help change people's lives. And again, if it doesn't last past the 60 days, it can at least introduce them to something that they would have never been introduced to before. So, again, this is something that I'm hoping that will be used quite widely across our space.
I also just wanted to piggyback on Samir's comment, which is, I think, if you look at risk, right, because not everyone is going to be a candidate for DRG. We have plenty of patients who may be lifelong anticoagulated, and their cardiologists they say, hey, look, they've had 3 or 4 PEs and they cannot come off their anticoagulation under any circumstances. Or patients who have had numerous surgeries and they say, whoa, I'm not really interested in you going near my spine. And so, if you look at the classification of PNS, even by, some of the societies like ASRA, that group has classified PNS as a low to intermediate risk procedure. And so I just think particularly for some of those patients who have been through a lot as well and may not be willing to commit to something bigger, this is a real easy sell to say, hey, look, this is low risk. And as all the other points Samir said, is that you can get durability. And so I think those are the big take homes, really.
And Scott, I'll just say one more thing, and I'm going to piggyback off you too.
Yeah.
I think you talked about risk. I think what we're forgetting about also is a cancer pain population. There are people that really, I think you've had cases, Scott, if I'm not mistaken, of patients that, almost end of life, and they just need something to get them through, and they can't go through a big surgery, or they have this refractory neuropathic pain, and to offer those patients those treatments, it's just, it really is special. So I think, there's so many different unique opportunities and settings, and it's just our creativity that can allow us to do this. But sorry, Tim, I didn't mean to.
No, I think that was, I didn't even think about the cancer pain population end of life. I think that's a great thing to bring up, Samir. Thank you for that. I think our listeners will enjoy hearing about that. And no, I was just going to make a point for our younger listeners out there. When I certainly love DRG, and it's a big part of my practice, but when I'm going to do a DRG, I always request an MRI for surgical screening, always, right? So a lot of times, I see someone who I think may be a DRG candidate, whether it's on label, lumbar, T10 to S2, or whether it's off label, I'm at C7 or C8, wherever I may be going. But I get that MRI, and a lot of times, even though they were a perfect candidate, the MRI doesn't support it, right? The spine is too advancedly diseased. And so I think the good thing about this therapy, in my opinion, from everything in the guidelines that we talked about, is that the low risk is there, right? Somebody has a bad spine, they have the anticoagulation, all those factors. This is a low risk option for them, and may give them great relief. So I do think that when that surgical screening MRI isn't pristine, and you're worried about entering the area, you can't forget this therapy, because it's always in the back of my mind. Okay, well, I can't do what I was going to do originally. Guess what? I'm going to have another good therapy for that patient. And the shoulder, I always go to this first, in the shoulder versus the spine. I think it's just a much better way to go. Suprascapular X-ray is so nice and does so well. And that's probably my most common target. And the other options is cervical intervention in the cervical spine, which I do, but it's a little bit bigger deal, a little bit more risky. So I do think this is a great option. So I like the points both of you made about that. Patrick, I think you have another question before we call it a day.
Yeah, I'm just wrapping up with that answer, piggybacking off all three of you guys. I agree. Anyone with moderate to severe foraminal stenosis, I would definitely choose a PNS option first to stay away from that foramen. So yeah, we'll wrap up with the last question or two. Tim, we may give you the last question, but where do you guys see 60-day PNS in the next 3 to 5 years? Where do you see this going with data, more pain generators, more studies? Scott, we'll have you start off, and then Samir will have the answers.
Yeah, I think we're at the tip of the iceberg, both with 60-day PNS as well as PNS in general. I mean, this is really, I've said it before, I feel like we're in a PNS renaissance right now of, we have all these ideas and the technology has to catch up. But I think the user experience for patients, I believe that is where a lot of the advancements are going to take place. Smaller wearables. I mean, my hope with 60-day therapy and PNS in general is smaller wearables, more ergonomically acceptable devices for patients, and I more data, obviously, for some of these other indications that we talked about, evolving indications like some of the nerves projecting to the head and neck area. I think all of those are going to be on the horizon. I always say PNS and even 60-day PNS, there's a patient commitment. This isn't a set it and forget it sort of therapy. There are wires, there are cables, there are bandages. Yeah. And so I think the more that we can miniaturize and make that process more approachable for patients, to make compliance better, to make it accessible for more patients, I think that's where we're headed. And I'm excited to see kind of where the technology and where some of these advancements are going to take us, in addition to the data that's going to be forthcoming.
Everything that he said, and then I'm going to add something that's really important to me is advocacy and policy. I think we can't do any of this without the advocacy and policy. And it's the frustration of talking to insurance companies and saying this is experimental and investigational. So Tim, Pat, I commend you for ASPN putting this out, because, when you have consensus guidelines from a very respected society like ASPN that's evidence-based, it's going to rival RCTs in terms of what the healthcare companies want. So what we're doing is building a really good base and foundation. So when I go to talk to, or when Scott goes, or anybody goes and talks to the insurance company, we have these guidelines to stand upon. We need more of that. We need more evidence out there. But again, this consensus evidence guidelines is probably just as helpful as a large RCT, and making sure that we move this from experimental investigational to actually medically necessary. So I think that's really, really important. So in the next 3 to 5 years, I'm hoping we get more approvals for this, more authorizations. I know I'm working within my house system to get this approved for a large patient population. So, and the other thing that I'm excited about is, I think we haven't really touched upon, but the guidelines did talk about very shortly, was the acute pain. So using this in acute pain settings would be pretty fun and exciting as well, because the opportunity to reduce, and again, speaking of Scott's the patient experience, the wearability, but the other experiences, like how about post-operative pain? Can we reduce the opioid the need for opioids? Can we have other secondary impacts on opioids reduction over time in the patient? And really the patient preference for probably not wanting as many opioids and having less, just a better recovery. So I think, the studies from Bielefeld and others have already shown this, that we actually can have quite a bit of reduction in opioids, better recovery, easier recovery, faster recovery. We look at maybe ability for prehabilitation in some of these patients. So there's so many different things that we can look at. So I'm excited about, and a little nervous about it too, with regards to payer access. I know we're in a fight with Noridian right now out in California, where, they've decided that unilaterally to say that, despite Medicare approving it for everything else, we're not allowed, we have all these different requirements out here. So we're working, we'll keep working, and anybody else who wants to join that fight, come along. But this is a tip of the iceberg. I'm super excited and just ready to continue to use this therapy.
All right, so I'm going to ask the last question to all three of you. You're getting asked this question as well. Your comments
on the
first.
spot.
A few comments first, and this is for the I know some insurance folks listening to this podcast. A T code means something is experimental, and then they get through the process and they get brought and they have a CPT code, and then they get approved by CMS and FDA. So for the insurance companies out there listening to this, that is no longer experimental. Quit lying to your patients and to us. That's a lie.
I agree.
We all know it's a lie. Quit lying. And it's really annoying. So thanks, Samir, you got my blood pressure up a little bit. That's number one. Number two, I think I want to shout out to Hemant Kalea, who Hemant does such a great job with advocacy for ASPN.
Yeah.
Mark Malinowski certainly lends a great hand. They guys have done great work along with some other people on their committee. So Hemant really uses these guidelines and really goes out and fights for things. And Maria and Dave and the leadership at SPR have done a great job of really supporting advocacy. So I want to give them some praise. Here's my question. In London at ISPN, I know we've got some we have 12 Iraqi physicians signed up to come, which is exciting to me. We've got 2 physicians from Iran. We've got a physician from Mongolia, one from Nigeria. So, we have these people that are in different parts of the world. And eventually, I'm hopeful the 60-day PNS will be available in more locations. It is less expensive than a permanent IPG would be. So I think there is a chance we might get more access to patients in other areas of the world. So if you had to give one word of advice to someone who've never used this therapy before and they're going to go back to their homeland, I agree with everything Samir said earlier. I do this under local in my office with ultrasound. It's so easy to do. What's your advice if you would to give them a pearl about this therapy if they're going to go back and that's going to be their main source of neuromodulation? And I'm going to make it hard on Patrick. I'm going to start with Scott. I'm going to go with Samir, and then Patrick get the last answer to that. Then we'll close.
Oh, one pearl. I'm left with one pearl.
Give them some advice when they go back. Give them the best.
Yeah. Yeah. I would say my one pearl would be start with one target, start with something simple, right? A group of patients that you know well, and start with that one condition or target. You mentioned, Tim, a little bit earlier, shoulder, how that has been a game changer. That would be, people say, what would be your first thing, your first target to go after? I'd say pick something simple, something that's comfortable, something that you're going to feel good about, and then plan on growing your portfolio from there. But I guess it would be the mantra, KISS, keep it simple, stupid. Start with something elegantly simple, and as you get more experience, you can grow out from there.
Great thoughts. Samir?
I'm going to kind of piggyback off him again. I've been doing that all podcast, but I agree. You got to start with something simple, something approachable. But another pearl I would give them is just to say that, really the durability, the potential durability for this is something to keep in mind, that, this is something that you put in and you might have to do it. You don't have to do it. It could last longer than the 60 days. And I think that's something to just take home. But pick a target, stick with it. Give it a chance, give it about 10 or 15 of those patients and see how they do.
Great thoughts. Patrick?
Yeah, similar response. Pick a target that you've had experience with doing nerve blocks, or, for example, I do a lot of genicular nerve blocks, RFAs. That's an easy one for me to set up with your post-surgical knee patient. Those are typically home runs. So pick something read up on the guidelines. There's a lot of great evidence on that, and pick something, and that'll set you up for success.
Fantastic. Patrick, you want to ask the closing thoughts here?
Yeah, no, again, thank you guys for joining us. You know, you guys did a tremendous job on the ASPN guidelines for a 60-day peripheral nerve stimulation. Like Samir, you said, I think this will serve as the gateway to peripheral nerve stimulation, and, you know, all of the targets, Scott, that you mentioned that you've had success with. I think that's great. And Tim, obviously, with your leadership and moving the space along, congratulations with all that. So appreciate you guys being here. This wraps up another episode of the Pain Unfiltered podcast. Thank you all for joining us.
Thank you.